Our next speaker and final speaker of the morning is Dr. Padmashree Chaudhury Woodham. She's someone that I know quite well. Dr. Woodham serves as a member of large on the GOGS Executive Committee and Advisory Council. And thank goodness she served as the chairman of this year's annual program planning committee. I can't tell you how much work Dr. Woodham has done to help put this meeting together, both in its original and its all virtual platforms. And I'm incredibly grateful for all of that energy and attention to detail. Dr. Woodham is board certified in OBGYN and maternal fetal medicine. She earned her medical degree from Emory University and completed both her internship and residency in OBGYN at Emory University School of Medicine. Thereafter, she went and completed a fellowship in maternal fetal medicine at the University of North Carolina, Chapel Hill. Dr. Woodham is an associate professor of OBGYN at Mercer University School of Medicine in Macon, Georgia. She currently serves as the director of Women's and Specialty Services Division at the Medical Center Navicin Health. Please give a warm welcome to Dr. Woodham and her lecture, very appropriately titled, What a Pandemic, Infection Prevention and Treatment for COVID-19.
Hi, everyone. My name is Champa Woodham, and I am a maternal fetal medicine specialist at Interim Health Navicin. The subject of my talk today happens to be the very reason why we all cannot be in person for our GOGS annual meeting. COVID-19, and what a pandemic it has been. I have no financial disclosures. Many of you have reached out to me with specific questions regarding COVID-19, and my goal is to try to answer the most frequently asked questions. That is why the objectives of today's talk are to differentiate the mechanism of action of mRNA versus DNA COVID-19 vaccines, describe published data regarding COVID-19 vaccination, discuss advisories made by governing bodies regarding COVID-19 vaccines, explain treatment of COVID-19 in pregnancy, and given the current state of the pandemic, I have added an additional objective, and that is to better understand the Delta variant. You might have seen pictures of the SARS-CoV-2 virus studded with its distinctive spikes, which are proteins that it uses to enter human cells. These so-called spike proteins make a tempting target for potential vaccines and treatments.
How do mRNA vaccines work?
Instead of using a small dose of live or dead virus like some other vaccines, mRNA vaccines like those made by Pfizer and Moderna use a tiny piece of the virus's own genetic material to manufacture the spike protein of SARS-CoV-2. The mRNA is contained within a lipid nanoparticle that is very unstable and rapidly degraded within days. It is removed by the lymphatic system and never enters the nucleus or gets integrated into cell DNA. Once this mRNA is injected into the muscle, ribosomes within cells translate the mRNA, and the cells start to manufacture the spike protein. The spike protein is then recognized by the immune system, after which antibodies are formed. There is no pathway for an mRNA construct to alter the genes of the host or the fetus of a pregnant patient. Given how mRNA vaccines act locally and are rapidly degraded and removed by the lymphatic system, the vaccine is not able to reach and cross the placenta.
How do DNA vaccines work?
DNA vaccines, like that created by Johnson & Johnson, are also based on the virus's genetic instructions for building the spike protein. But unlike the Pfizer and Moderna vaccines, which store the instructions in single-stranded RNA, the J&J vaccine uses double-stranded DNA. The researchers added the gene for the coronavirus spike protein to another virus called adenovirus 26. Adenoviruses, as you know, are common viruses that typically cause colds or flu-like symptoms. The J&J team used a modified adenovirus that can enter cells but can't replicate inside them or cause illness. Johnson & Johnson's vaccine comes out of decades of research on adenovirus-based vaccines. In July of 2020, the first one was approved for general use, which is a vaccine for Ebola, also made by Johnson & Johnson. Some other coronavirus vaccines are also based on adenoviruses, such as the one developed by the University of Oxford and AstraZeneca, which is a 2-dose vaccine using a chimpanzee adenovirus. The J&J vaccine is a game changer because it requires only a single injection. In addition, adenovirus-based vaccines for Covid-19 are more rugged than mRNA vaccines. DNA is not as fragile as RNA, and the adenovirus's tough protein coat helps protect the genetic material inside. As a result, the J&J vaccine can be refrigerated for up to 3 months. This diagram currently demonstrates how the genetic material in an mRNA vaccine is translated into the spike protein. The difference with the DNA vaccines is that the genetic material in the adenoviral vectored vaccines first enters the nucleus to produce mRNA, which then takes us right back to the pathway of the other mRNA vaccines.
What do we know about efficacy and safety?
Here is a screenshot of the 2 publications from the Pfizer and Moderna trials that were published in the New England Journal of Medicine in December of 2020. I am going to focus on the Pfizer trial, but I want you to know that both vaccine trials were similar in methodology as well as findings. This table shows vaccine efficacy against COVID-19 at least 7 days after the second dose. The first row includes all patients with no evidence of COVID infection at baseline. This was determined by obtaining blood samples from these patients to see if they had ever had COVID. The second row includes all participants. As you can see, vaccine efficacy was 95% across the board. Why is this relevant? Well, if you have had COVID previously, vaccine is still recommended for you because it still demonstrated some benefit. To be clear, 95% efficacy is at the top of the heap of any vaccine that is currently available worldwide. This table helps to demonstrate that the vaccine was effective across all sorts of subpopulations. Young to old, male versus female, across race and ethnic groups, and across different countries. Now, this is some of the most exciting information that came out of the initial studies on the Pfizer and Moderna vaccines. This is looking at a Kaplan-Meier curve of time to COVID infection following the first dose. The red line represents the vaccine group, and the blue line represents the placebo group. The inset in the upper left-hand corner looks closer at the data from days 0 to 21. Starting at about 12 days after the first dose, you begin to see a divergence of the two groups, meaning even one dose has very meaningful efficacy to prevent infection. This does not mean we want to encourage people to get only one dose, but it does mean we start to see protection very early.
Right.
Let's talk a little about side effects. This is data again from the Pfizer trial, and data from Moderna look nearly identical. We will start with local side effects that include pain at the injection site, redness, and swelling. As you can see, most patients described mild and moderate symptoms, which are colored green and blue. Orange represents severe side effects, and red, grade 4, which is severe side effects that required some sort of medical management. As you can see, there are only a few in the severe or orange range, and none in the grade 4 or red colored range. These data look very similar between dose 1, which is the bar graph on the left, and dose 2, the bar graph on the right. This figure shows systemic side effects like fever, fatigue, headache, muscle pain, and joint pain. What has raised the most questions, particularly for pregnant women, is the symptom of fever and what that represents. That's the very first bars that you see on the left side. This graph has the same color scheme as the previous graph. Just under 4% of the population experienced fever in the vaccine group, but most of them were in the mild to moderate range. That does go up somewhat after the second dose to about 16%. But if you look at the bars to the right-hand side in white, those represent the use of antipyretic medication. It is important to note that you still see a good number of folks in the placebo group that ended up using antipyretic medication. Here are screenshots of the one-page summaries of the Pfizer and Moderna trials. These are very helpful to have on hand as a quick reference of these two studies. At the end of January, the NIH published this news release. According to an interim analysis of phase 3 clinical data conducted January 21st, the J&J vaccine appeared to be safe and effective in preventing moderate and severe COVID-19 in adults. The interim analysis assessed 468 cases of symptomatic COVID-19 among 44,325 adult volunteers in 8 different countries. The investigational vaccine was reportedly 66% effective at preventing the study's combined endpoints of moderate and severe COVID-19 at 28 days post-vaccination among all volunteers, including those infected with an emerging viral variant. Geographically, the level of protection for the combined endpoints varied. 72% in the US, 66% in Latin American countries, and 57% in South Africa. The investigational vaccine was reportedly 85% effective in preventing severe and critical COVID-19 across all geographical regions. The onset of protection was noted to be as early as 14 days post-vaccination. There were no deaths related to COVID-19 in the vaccine group, while 5 deaths in the placebo group were related to COVID-19. On April 13th, the CDC and FDA put the Johnson & Johnson COVID-19 vaccination program on hold out of an abundance of caution based on a possible safety signal that required further investigation. As of the day prior, approximately 6.85 million doses of the J&J vaccine had been administered in the U.S. Among all of those recipients, 6 cases of a rare type of blood clot called cerebral venous sinus thrombosis, or CVST, was reported to the Vaccine Adverse Event Reporting System, VAERS. All 6 cases occurred in women aged 18 to 48. The interval from vaccine receipt to symptom onset ranged from 6 to 13 days. 1 patient died. Initial presenting symptoms were notable for headache in 5 of the 6 patients and back pain in the 6th, who subsequently developed a headache. 1 patient also had abdominal pain, nausea, and vomiting. 4 developed focal neurological symptoms, such as focal weakness, aphasia, and visual disturbance, prompting presentation for emergency care. The median days from vaccination to hospital admission was 15 days. All 6 patients were eventually diagnosed with CVST by intracranial imaging. 2 were also diagnosed with splanchnic and portal vein thrombosis. Unusual for patients presenting with thrombotic events, all 6 patients showed evidence of thrombocytopenia consistent with a condition known as thrombotic thrombocytopenia, with platelet nadir counts ranging from 10,000 to 127,000 during their hospitalizations. 4 patients developed intraparenchymal brain hemorrhage and 1 subsequently died. These reports following the J&J Covid-19 vaccine are similar to reports of thrombotic events with thrombocytopenia after receipt of the AstraZeneca Covid-19 vaccine in Europe. Based on studies conducted among the patients diagnosed with immune thrombotic thrombocytopenia after the AstraZeneca Covid-19 vaccine in Europe, pathogenesis of these rare and unusual adverse events may be associated with platelet activating antibodies against platelet factor 4, or PF4. Anti-PF4, also known as heparin PF4 antibody, can induce thrombotic thrombocytopenia in a small percentage of persons exposed to heparin. However, none of the cases reported from Europe had recent heparin exposure. Usually, the anticoagulant drug heparin is used to treat acute thrombosis. The rare complication associated with the AstraZeneca and J&J vaccines is not the same type of event, and anticoagulation for treatment of CVST is dangerous. Treatment should actually be IVIG or other supportive measures. Again, heparin is contraindicated in these cases. The VAERS has received no reports of CVST with thrombocytopenia among persons who received either of the 2 mRNA-based COVID-19 vaccines. At the time of the hold of the J&J vaccine, the CDC and FDA encouraged pregnant and postpartum women who wished to be vaccinated to receive the mRNA vaccines by Pfizer or Moderna. The CDC and FDA also recommended that for 3 weeks after receiving the J&J vaccine, one should be on the lookout for possible symptoms of a blood clot with low platelets. During the temporary pause of the J&J vaccine program, the CDC and FDA reviewed all reports of vaccine side effects and adverse events. As of April 23, 2021, more than 8 million doses of the J&J vaccine had been given in the U.S. As of that date, experts reviewing safety reports for the vaccine found 15 reports of women who got the J&J vaccine and later developed what is being called thrombosis with thrombocytopenia syndrome, or TTS. These reports suggest an increased risk of TTS 1 to 2 weeks after vaccination with the J&J vaccine. As of April 23rd, the reports reviewed all occurred in women between 18 to 59 years of age. This represents a reporting rate of 7 such events per 1 million vaccinations among women 18 to 49 years old, and a rate of 0.9 per 1 million vaccinations among women 50 years and older. Therefore, for all women, this is a rare adverse event. For women 50 years and older, as well as men of all ages, the adverse event is even more rare. Reports showed that symptoms of this adverse event started between 6 to 15 days after vaccination. The CDC and FDA recommended that use of the J&J vaccine resume in the U.S. effective April 23rd of 2021. A review of all available data at that time showed that the J&J vaccine's known and potential benefits outweigh its known and potential risks for those recommended to receive it. However, women younger than 50 years old especially should be aware of the rare risk of blood clots with low platelets after vaccination, and that other COVID-19 vaccines are available where this risk has not been seen. As of April 23rd, PTS has not been linked to the Pfizer or Moderna COVID-19 vaccines after more than 210 million doses administered. The pause allowed the CDC to communicate with healthcare providers and re-emphasize the importance of reporting severe events in people who have received this vaccine, as well as how to report such events. The pause also gave experts time to carefully review all available data and conduct a risk-benefit analysis around the use of this vaccine. To better describe just how rare the complication of CVST is as a result of the J&J vaccine, let me give you some comparisons. In the general population, the chance of CVST is 0.5 per 100,000 per year. COVID-19 infection increases the relative risk of CVST to 4.5 to 20 per 100,000 COVID cases. Pregnancy and the use of OCPs also increase the risk of CVST given the hypercoagulable states they cause. After administering 100,000 J&J vaccines, there may be 0.09 cases, which is about 1 in a million. So as you can see, a relatively low risk.
After COVID infection, what is the chance of reinfection?
A study from Denmark is the largest to date that looks at the chance of reinfection. They looked at 4 million people, which is about 69% of their population. Protection against reinfection was noted to be about 80%. However, immune memory is heterogeneous per person. There is up to a 100-fold range between two people, which is a big difference. The COVID vaccines appear to be eliciting more immunity than infection itself. Both Pfizer and Moderna vaccines elicit higher neutralizing antibody titers than natural infection. So, you should still get vaccinated even after COVID-19 infection. Natural immunity is not always better. HPV is the best example of that, as the vaccine confers a significantly greater immunity than infection from HPV itself.
What about the Delta variant?
The Delta variant was first discovered in India, which should not be surprising. At one point in May of this year, India had approximately 400,000 cases of COVID-19 infection per day. Variants occur stochastically because of the number of cases you have. So, the more cases, the more likely a new variant comes up. The Delta variant is also more contagious. This is described as R0, or the number of people that one person can infect. The R0 for the original strain of COVID-19 was about 3. The R0 for the Delta variant is around 7. The number of patients hospitalized as a result of COVID-19 infection is steadily increasing, and as you can see, the rates in the U.S. are significantly greater than several other countries. As of August 10th, there were over 70,000 patients hospitalized as a result of COVID infection in the U.S., with a 7-day rolling average of 66,000. This graph shows the slopes of each of the waves that have occurred in the U.S. in regards to hospitalizations from COVID-19 infection. The lowest level during the pandemic was at 15,000. However, you can see the steep slope that we are currently on as a result of the Delta variant. This heat map shows how COVID-19 is affecting the United States. As you can see, the greatest effect is being seen in the southeast area of our country. This diagram represents each state as colored circles and looks at confirmed COVID-19 hospitalizations per 100,000 residents as compared to percent fully vaccinated people in each state. As you can see, Florida has the highest rate of hospitalization currently in the U.S. Every state with a higher hospitalization rate than the country overall has a lower vaccination rate. And similarly, every state with a higher vaccination rate than the country overall has a lower hospitalization rate. What is concerning is that though the number of COVID-19 patients in the hospital is increasing in the United States compared to other countries, the number of daily COVID-19 tests being performed in the U.S. is significantly low. As a result, this graph is likely underrepresenting the number of new confirmed COVID-19 cases in the U.S. currently. Current data shows that people who have not been vaccinated have about an 8-fold increase of coming down with SARS-CoV-2 Delta variant. Hospitalization risk drops 25-fold for those that have been vaccinated compared to those who have not. Data published in Nature last month showed that people who have had 12 months pass since their first infection with SARS-CoV-2 have a reduced effectiveness of their antibodies against the Delta variant. This was a cohort from Strasbourg, Germany, where they had 26 subjects that were previously infected with SARS-CoV-2, and they looked at their convalescent sera, which basically means they looked at their antibodies 12 months after the onset of symptoms. They measured the efficacy of their ability to bind to the virus and looked at 4 different variants of the virus. Then researchers measured the ED50, which is the effective dose at which the antibodies are able to neutralize 50% of the virus. It is a surrogate for immunity. You want the thick black line to be high, meaning effectiveness is high. As you can see, effectiveness against the Delta variant was low after 12 months post-infection. From that same cohort, they took subjects that had previously been infected with SARS-CoV-2, and they looked at the response after one dose of a vaccine. And you can see what just one dose did to the ED50, particularly against the Delta variant. In another cohort, this time in France, they looked at the ED50 3 weeks after the first dose of the Pfizer vaccine. So, essentially, right before the subjects received their second dose. And as you can see, there are very low levels of protection from the Delta variant, arguably lower than the natural infection levels of antibody in the cohort we saw in Germany. However, 5 weeks after the second dose, or in other words, 8 weeks after vaccination, you can see that these ED50 levels have come up substantially. They also did this study similarly with the AstraZeneca vaccine and got similar results.
Does COVID vaccination cause infertility?
Simply put, no. The COVID-19 vaccines have not been shown to affect fertility. Some of you may be wondering, where did this rumor start and how did it spread? Well, we can thank Michael Yeadon and the social media app called WhatsApp for all the drama. Michael Yeadon was employed a decade ago by Pfizer for about 6 years. He was suggesting similarity between the spike protein and a protein in the placenta called syncytin-1. And as a result, he was proposing that antibodies that would attach to the spike protein might also attach to the placental proteins and then might lead to reduced fertility. We have quite strong evidence that this won't be the case because there's really not much similarity between the spike protein and syncytin-1. Also, a laboratory team at Yale has taken antibodies from people who have had COVID-19 infection and seen if they bind to this placental protein. And the result was they did not.
What about COVID vaccination and pregnancy?
In humans, we initially knew only a little, as individuals who were pregnant could not be enrolled in the studies. They had pregnancy testing at the time of enrollment. In the Pfizer trial, 23 women conceived after enrollment, with 12 in the vaccine arm, and there were 13 pregnancies in the Moderna trial, with 6 in the vaccine arm. At the time when the emergency use authorization was given for the Pfizer and Moderna vaccines, there were no adverse outcomes in those pregnancies up until that point, but there was still not enough time to look at the full outcome of those pregnancies. It is important to note, though, that these were all women who conceived after receiving a dose of the vaccine or were periconception and had a negative pregnancy test at the time of vaccination. And again, there were no increased risks of miscarriage or other outcomes by the time of the EUA. The FDA reviewed animal data from DART studies, which stands for Developmental and Reproductive Toxicology, for both of the vaccines, and they noted no effects on fertility, fetal development, and postnatal development. On February 1st, Dr. Anthony Fauci, the nation's leading infectious disease expert, said during a media roundtable at the IAS Covid-19 conference that about 10,000 women in the U.S. had been vaccinated since the FDA authorized the 2 mRNA vaccines, and so far there had been no red flags. The CDC guidelines at that time said the decision to be vaccinated should be up to the mother in consultation with her healthcare provider. FACOG and SMFM stated that COVID-19 vaccines authorized by the FDA should be made available to pregnant women who choose to get the vaccine. But the World Health Organization recommendations seemed to contradict U.S. agencies and organizations. WHO guidelines said pregnant women may be vaccinated only if they are at high risk of exposure to the coronavirus, such as working in healthcare, or if they have underlying medical conditions that put them at risk for severe disease. Later, in June, the WHO slightly adjusted their recommendations to state, WHO recommends vaccination in pregnant women when the benefits of vaccination to the pregnant woman outweigh the potential risks. The CDC has finally moved off its neutral stance on whether COVID immunization is safe in pregnant women. A CDC analysis of safety data on 2,500 women showed no increased risks of miscarriage for those who received at least one dose of the Pfizer or Moderna vaccine before 20 weeks of pregnancy. They found the SAB rates were about 13%, which is within the normal expected range. That led to the August 11th update of their recommendations that state COVID-19 vaccination is recommended for all people 12 years and older, including people who are pregnant, breastfeeding, trying to get pregnant now, or might become pregnant in the future. As of the end of last month, only 22.7% of pregnant people were fully vaccinated.
How do you manage COVID-19 in pregnancy?
According to a CDC study published in November, pregnant women 35 to 44 years old with COVID-19 were nearly 4 times as likely to require invasive ventilation and twice as likely to die than were non-pregnant women of the same age. A more recent study from the University of Utah Health examined medical records of 1,219 pregnant women from 33 hospitals in 14 states from March 1st to July 31st of 2020. This study also found that pregnant women who become severely or critically ill from COVID-19 are at a greater risk of dying and experiencing serious pregnancy complications compared to pregnant women who were asymptomatic or had mild symptoms. Of the pregnant women who were critically ill, half of them required a cesarean section, 50% of their babies went to the NICU, 42% had a preterm birth at less than 37 weeks, and 40% developed high blood pressure during pregnancy. Various hospital systems have developed protocols in regards to the management of COVID-19 positive pregnant women. This particular protocol is from Perinatal Associates of New Mexico. In their protocol, patients with no symptoms or mild symptoms that did not include shortness of breath or any abnormal chest imaging can self-isolate at home and monitor for disease progression. They should be informed to call their OB provider if their symptoms worsen. Patients with moderate COVID-19 which would be patients with lower respiratory disease evidence on imaging, or oxygen saturations that are greater than or equal to 94% on room air, as well as those with severe disease, meaning a respiratory rate greater than 30, O2 sats less than 94%, or lung infiltrates greater than 50%, should all be admitted. Those with a viable gestation should be admitted to L&D, and those that are non-viable should be admitted to a medical floor. MFM as well as internal medicine should be consulted for these patients, and the critical care team should be informed of the patient's admission. Patients who present with critical COVID-19 infection, meaning they have respiratory failure, septic shock, or end organ dysfunction, should also be admitted to the hospital but go directly to the ICU regardless of the gestational age. If they are viable, the L&D nursing staff should be informed so that they can coordinate management of monitoring the baby in the ICU, as well as prepare for a possible emergent C-section. The primary management of these patients should be by the critical care team, but of course MFM and OB should be consulted. Initial evaluation of the patients with moderate, severe, or critical COVID-19 should include a chest x-ray, a CBC with CMP, and procalcitonin, as low levels of procalcitonin are suggestive against bacterial pneumonia. Patients who are admitted should have supplemental oxygen to maintain their PO2 at greater than or equal to 95%. They should also receive VTE prophylaxis, such as heparin 10,000 units sub-Q twice a day. They should also be started on a course of glucocorticoids. If the patient is less than 23 weeks, this protocol advises using methylprednisolone 32 milligrams PO or IV daily for 10 days or until discharge home. If they are greater than or equal to 23 weeks, they recommend using dexamethasone 6 milligrams IM Q12 hours for 4 doses, and then switching over to methylprednisolone 32 milligrams PO or IV to complete 10 days or until the patient is discharged home. They also recommend the addition of antiviral therapy with remdesivir 200 milligrams IV on the first day, followed by 100 milligrams IV daily for 4 days. This can be continued for 10 days if there is no clinical improvement on day 5. The other antiviral that they recommend is oseltamivir 75 milligrams PO BID for 5 days when the flu virus is active, and to discontinue this if flu testing comes back negative. They also recommend considering early use of convalescent plasma in severe and critical illness. In regards to timing of delivery, this should be considered if the patient is greater than 32 to 34 weeks gestation, or if there is refractory respiratory failure or worsening critical status. Discharge of COVID-19 patients is the same as any other condition and should be determined by the ongoing need for hospital care and inpatient monitoring.
So how do you counsel your patients about the vaccine?
You should use shared decision making, like counseling for TOLAC. As providers, it is very important that we know where to access information that can help us in guiding our patients with the decision making of whether or not to receive COVID-19 vaccination. This particular handout is helpful to guide a provider in that sort of conversation and can be found on the ACOG website. This information found on the SMFM website is also very helpful and available in Spanish as well. Finally, this model created by Bay State is a very easy to read handout that can also be given to patients to better understand COVID-19 and vaccination. I want to review again the Vaccine Adverse Event Reporting System, VAERS, so that we are all aware of where we as providers or patients themselves can go to report any potential adverse reactions. This can be accessed online or they can be contacted via phone or email. I also recommend that this one-page handout be given to each patient when they get vaccinated. This helps them enroll into the VSafe registry by using the QR code at the bottom right corner. After they enroll, they will receive questions via text message at various checkpoints after their vaccination. At first, they will receive daily check-ins during their first week post-vaccination and then weekly until 6 weeks post-vaccine. After that, additional health checks are performed at 3, 6, and 12 months post-vaccination. Being involved in the VSafe registry includes active telephone follow-up with vaccine recipients that report any event with health impact during any health check. This flow diagram shows how all this information comes together. The patient registers for the VSafe health checker and receives the text messages from the CDC regarding their health checks. If they report any clinically important event, then the call center will contact the vaccine recipient to follow up. I want to close with this Swiss cheese model of how to defend against a respiratory virus pandemic. There are both personal and shared responsibilities, and we must recognize that no single intervention is perfect at preventing spread. Each intervention or layer of cheese has imperfections or holes, but multiple layers improve the success. If we continue to encourage the personal and shared responsibilities among our colleagues, friends, and patients, there is still hope that we can defend ourselves against this horrible pandemic.
Thank you so much for your attention. Now we will take any questions.
Wow. Thank you, Champa, so much. And thank you to your little helpers that helped with the transitions between the topics as well. That was just a wonderful review, not only kind of talking through where we've been, but also literally up to the minute with some of the most recent recommendations. So thank you so much. I want to, there's a couple of chats or questions in the chat. Dr. Reed, if you're available and you would like to unmute, do you want to ask your question?
Yeah, my question is, if a patient has had reactions to the flu shot in the past on 2 separate occasions, pretty severe reactions, are they a candidate for the COVID vaccine because it's a different method?
Yeah, so patients that have had a reaction to the flu shot should not be concerned in regards to that type of reaction with any of the COVID vaccines because the ingredients are very different. In fact, if you were to really look at each of the ingredients on the vials, most of these things are quite natural, actually. And so I have not experienced any patients of mine that have gotten the flu shot and reported a past event to also have any kind of event aside from the usual just soreness and maybe some weakness after getting COVID shot.
And then Dr. Dunson-Allen.
Can you hear me?
Yes.
Okay, terrific. Again, thank you so much. This was truly one of the best presentations I've ever seen, from soup to nuts, bringing everyone up to speed on the science behind it. Really appreciate the detail. At our hospital, we actually currently are working on getting maternal fetal medicine support and have them via telephone, but we actually also engage our ID colleagues a lot. I wanted to ask your thoughts on that, and also your comments regarding the use of monoclonal antibodies.
So in terms of the first part of your question, we include our ID colleagues as well. I know that the protocol from New Mexico did not include that in their flow diagram, but we do. We work very closely with our ID folks, actually just even with management of our pregnancies with HIV or hepatitis. So of course, when COVID came along, it was a no-brainer for us to include them. So I think if you have access to ID colleagues, it's always good to have them as part of the conversation. In terms of monoclonal antibodies, part of the reason I didn't put that in the presentation is because there is limited information in regards to that and pregnant women. Obviously, we have literature that shows that there has been benefit to other patients, but right now there's not much that we can comment on from a pregnancy standpoint, which is why I kind of steered away from that. But I'm hoping we'll get more information as we gather more data from the VAERS.
You had
Thank you so much.
Oops, sorry about that. Dr. Bonk, you had a comment and a question.
What about vaccinating women as they go home postpartum? I know that's late, but all these people say, oh, I'll just wait till I have the baby. Well, you've had that baby. Let's get your first shot in. Is anyone doing that yet?
So I know at our hospital, we don't have the vaccine currently to give to inpatients, and that's one of our next projects, is just system-wide to have that available. I think what you're suggesting, Dr. Bonk, is a great idea. We've talked about that. I want to have it available even when my patients get admitted to the antepartum service, even if they're there for a couple of days, just like we would offer the flu shot during flu season, we should be able to offer this. And so I'm really trying to encourage the hospital to get a supply so that we have that opportunity, whether it's antepartum, postpartum, or whenever. But yeah, my answer to that is it's best to get it at any time. And if we can encourage our hospital folks to purchase the vaccine and have it available to give to folks, that would be the best way to capture an audience.
And then both Dr. Ellis and Geary were giving some of their experiences to some of these comments. I'm not sure if you guys want to share. And then this will be, I think, just in the interest of time, the last things that we share together today.
Let me can you hear me? It's Dr. Ellis. Can I make a quick comment?
Yes, please.
Yes.
Yes, we are strongly encouraging our pregnant women in clinics to get the vaccine. We do have a walk-in clinic at Grady, open 5 days a week, where patients can go straight down and get it. We are still encountering a lot of patient hesitancy with respect to vaccines. In the ER here at Grady, anybody coming in that wants the vaccine is getting the Johnson & Johnson, but we are not doing that. And part of the reason we have been hesitant to give it to patients, say, that are admitted on our APU service or coming into triage, is that it would most likely, I suspect, be the Pfizer vaccine. We have no way to follow up and make sure those patients are completing the doses. So we've been a little hesitant, although there have been discussions about doing that at Grady. And we are offering the monoclonal antibodies to patients that qualify for it. But again, interestingly, have met patient resistance. They don't understand it. They're not interested in it. So I think we've only administered it maybe in 4 cases that I'm aware of. Dr. Geary may have some additional experience.
No, I don't have any additional experience with that.
And I'm just wondering if we know what the hospitals around the state are doing, especially the smaller units. Do they have things like remdesivir available, or dexamethasone, or any doing the monoclonal antibodies, or are they having to transfer patients out if they want that? Or does anybody know, or is there any way we could look at that?
Well, I mean, I know from my experience, a lot of those patients are getting sent over to our hospital. And part of the problem right now is we're so full, our ICU beds are full. So we're having to divert those patients over to either your institution, Dr. Ellis, or other RPCs. But yes, some of the smaller hospitals based on the phone calls I'm getting, it appears that they don't have those treatments available there. And so they're having to ship those patients out and they have to hope that we have a bed open. I don't know if some of the folks that are on this meeting that are part of the smaller hospitals, they may be able to comment better.
Yeah, we're having the same
This might
experience.
be
Grady has actually been on diversion Grady's been on diversion since sometime last week because of the number of patients in-house with COVID. We've not been on diversion on labor and delivery, and we have taken quite a few patients with COVID from other hospitals.
This actually might be a good question to send out to the members of GOGS to find out what capacity they have to treat pregnant patients and what therapeutics they have available to them in order to treat versus shipping them to another facility.
And Sandra, it's Jane, I'll be happy to work with you on that. I think it's something we need to be able to know what our hospitals are capable of and what to expect as things worsen.
Let's meet next week.
Okay.
Awesome. Okay, well, thank you so much. I apologize. I'm sure that we could talk about this for a long time yet. There's a lot going on. But thank you for your discussion, Champa. Thank you for your presentation. Thank you all for your questions and comments. And that this has been just a really lovely morning.